All right, good morning or evening or whatever. This is ICU Doc Talk with ICU Doctor. We are today. Let's talk about illicit drugs and the medical complications that they have, and with possible withdrawals from them, and what I see with them. This is a trigger warning. I'm talking about illicit drugs. I'm talking about marijuana, methamphetamine, cocaine, heroin, opiates, and stuff like that. I've treated many patients that have had substance use disorder with a lot of these things. I will be talking about substance use disorder a little bit, but I'm mostly going to be talking about the medical management of patients like this. So if you feel like this is something that may trigger you with one way or the other, maybe do not listen this week. But anyway, here we go. Let's do it. I'm first going to be talking about cannabis, marijuana. It is the third most commonly used psychoactive substance in the world, which is after alcohol and tobacco. It causes euphoria, and it's also has sedative properties. It has analgesic properties as well, meaning it can treat pain. It can. And obviously the active drug is THC, which varies with potency of how whether it's smoked or eaten or whatever. Now, when I have a patient who actively uses marijuana, they use it today, they use it this morning, something like that. How does it affect things? It doesn't affect medical management as much as you may believe it does. So I think let me back up. Number one, I don't care. When I have a patient who does I'm going to probably accidentally say things in sensitive ways over the course of this podcast, so I apologize up front. I was about to say does drugs, which is a very dumb way of saying things. But someone who uses marijuana, I don't care if someone uses illicit drugs. It doesn't I truly do not have moral judgment about patient. When I have a patient and they're like, oh yeah, I did methamphetamine yesterday. I promise you, whoever's listening to this, I do not judge that person, because my perspective is, if someone has an addiction is a disease, is a medical disease, and addictions get to this point. By definition, they're outside that person's control. Now, maybe they made poor decisions leading up to addiction. Everybody makes poor decisions. We all make bad decisions. And then some people, we have genetic dispositions that lend more to addiction. Someone may, do some sort of illicit drug and then get away scot-free without an addiction. And then the next person, they experimented with it like the first person, and then they have an addiction for the rest of their life. And it's genetic proclivity. And that person who doesn't have the addiction, they just won the genetic lottery. They were able to experiment with drugs in high school or college or whatever, and they got away with it, right? That's outside of people's control. So I do not place moral judgment on people that have substance use disorder and that are addicted to substances like this. I do not. So when I have a patient and they're like, oh yeah, doctor, I did this, I don't care. Most people in medical professions don't. Maybe I'll back that up. I don't know. Maybe people do, maybe people don't. But it doesn't. It should not affect their care. Maybe it does at some places. And that's not right. But for one thing, I don't care. Be honest, because it really, really matters that your healthcare team knows if you are doing illicit drugs, like something as something that you may not think is a big deal, like marijuana. You need to tell us. So with marijuana, so if someone is actively using it as anesthesiologist or critical care, number one, I don't care. It's not a moral judgment, but I need to know. Because it does increase your tolerance for anesthetics. It definitely does. So if I have a 55-year-old guy, and rather than giving 150 milligrams of propofol it took 300 to get that guy asleep, that guy's probably doing some recreational drug use that he didn't tell me about, because no one should really take that much, even if they're a redhead, right, or even if they're on the heavier side. No one should take that much at that age group, So it often coincides with that. So we need to know. Mostly, I want to know about your marijuana use because I need to give you more anesthetic. You want to have the appropriate anesthetic to make sure you're sedated and to treat your pain. We need to know these things. I also want to know if you're on cannabinoids, other medications that are cannabinoids like Marinol, things like that, so that we can continue to give you those medications. If someone has cancer and they're on chemo and they're taking stuff like that. So we need to know those things. So withdrawal from cannabis, it's usually manifested by a constellation of signs. And it usually happens within 1 week after abrupt reduction or cessation of a heavy and prolonged use. The symptoms they range from really, really mild to severe. And the withdrawal has a lot of significance when the symptoms are severe to be distressing to a patient, when they interfere with like daily activities, activities of daily living. Sleep disturbance is also a big issue with cannabis withdrawal. Now, withdrawal from cannabis, it's not generally associated with like significant, vital changes like cardiovascular changes or something that might affect your nervous system, like other illicit drugs that I'm going to talk about. Now, there are synthetic cannabinoids, and abrupt cessation of those, they can lead to more physiological withdrawal symptoms, like hyperactivity of your autonomic nervous system. Like you can get high heart rate or blood pressure. You can have a lot of sweating, even seizure and altered mental status. I haven't seen this. That seems like a very rare withdrawal symptom from synthetic cannabinoids. And the reason I haven't seen it is if someone is on synthetic cannabinoids, we usually continue those when someone is in an inpatient. All right, that's enough about marijuana. Honestly, it doesn't come across, withdrawal symptoms from that. It doesn't come across in my clinical practice very often. So let's move on to opiates. So withdrawal from opiates is obviously a big, big deal. Now, it's not typically life-threatening withdrawal. So there are some illicit drugs that are life-threatening if you withdraw from them. But opiates are typically not life-threatening. Now, people that are withdrawing from opiates, they probably feel like it's life-threatening, and that they're dying because it's unbelievably unpleasant for these poor people. But it's not life-threatening. The typical signs and symptoms of withdrawal from opiates are, of course, craving for it, anxiety, restlessness, GI, distress, diarrhea, sweating, high heart rate, high blood pressure. And then untreated withdrawal usually results in relapse to use opiates. One thing to keep in mind is that patients with opiate use disorders, they usually have higher rates of other substance use disorders, especially nicotine. It's up to 85% concomitant use. And they also have higher rates of mental health disorders, up to 70%, especially major depression, panic, anxiety, generalized anxiety disorders, PTSD, and like antisocial personality disorder. So it's not just an isolated thing. Patients are complex, and they have complex reasons for their behavior. Now, if someone is trying to go through opiate withdrawal on their own, outside of a hospital setting, they're likely going to relapse, like I mentioned. So there is medically supervised opiate withdrawal. That's what detoxification is. When you hear it, what is detoxification? And that typically involves giving medications that reduce the severity of the withdrawal symptoms when someone stops. The main medications that are used with treatment of withdrawal symptoms are opiate and agonists, right? Agonist is a different drug that hits that same receptor, right? And the typical ones we use are like methadone and buprenorphine, which is a partial agonist. There's also alpha-2 adrenergic agonists. I won't get too much into that, but like medications such as clonidine. There's a lot of adjunct therapies that can be used for opiate withdrawal symptoms. Now, I'm not an expert in substance use disorder and detoxification, things like that, so I don't want to explore too much into that because I don't want to say the wrong things. My point is I take care of patients, whether they have, they've been in a car accident and they were using heroin that day, or they've been clean for 4 years and they're on methadone, right? I take care of all types of patients in the operating room doing anesthesiology or in the ICU if they're critically ill, right? Just because someone has substance use disorder, they get the same, I know I'm stating the obvious, they get the same issues that anybody else has, and they need to be in a hospital for many other reasons, not just because of opiate withdrawal use. So one of the main principles is if someone is on methadone, you keep them on methadone. You ensure that they took it that day. So if I have a patient that I know is on methadone, I'm like, did you take your methadone today? Usually they have, right? They're religious about it because it's helping them. It's providing that it's that got that nice sustained opiate release into their bloodstream. It's helping keep their cravings at bay. It's right. Methadone can literally provide support for someone overnight to keep their withdrawals at bay, get them out of unsafe situations, and it helps them move towards recovery. So I make sure that they've received it that day. If they haven't, I give it to them. If they weren't able to get it, whatever, I will give them methadone during the operation, before an operation. I will make sure they get methadone after the operation, or whatever it is. If they're on OxyContin, which is sustained release, which is typically not used for withdrawal symptoms, and I'm not encouraging that, but people can be on that. They can be on that if they have cancer pain or something like that. The point is, do not precipitate withdrawal symptoms with a patient that is hospitalized. Give them what they need in an inpatient setting. I usually take care of patients that have high acuity needs, like they're in the operating room or the ICU, right? So I make sure they are getting what they need. It is not my job and my role to fix where someone is at with their substance use disorder. It is my job to get them safely through whatever it is they need and to not precipitate withdrawal symptoms. And then maybe to set them up with chemical dependency, like counselors and detoxification program, if it's what they desire on their way out of the hospital, to set them up with those experts. Now, if someone is on something like Suboxone, which that's what it's called in the United States, that's the brand name, which is buprenorphine and naloxone, right? It's a partial agonist and a full antagonist of the opiate receptor that helps with substance use disorder. It helps you it helps give cravings. And the reason it's compounded that way, you can only take it as a pill. If someone tries to crush it up and put it in the bloodstream, the naloxone will counteract the buprenorphine and it won't be effective. So it discourages people to inject it because it won't do anything for it. They won't feel anything. They won't feel any opiate satisfaction. Anyway, so if someone is on something like Suboxone preoperatively and they need acute surgery, they're going to have surgery. Well, they're going to have acute surgical pain, right? After the procedure, they're going to have acute surgical pain. So if they're on Suboxone, which is buprenorphine and naloxone, they have a partial agonist going on in their body, opiate agonist. What that means is if I try to give them something like hydromorphone or fentanyl, something that's a full agonist, it's not going to be as effective because the buprenorphine is blocking the full agonist medications. So they may have pain, right? That uncontrolled pain after their surgery from acute surgical pain. So in my opinion, the best practice is if someone is on something like Suboxone before surgery, the best practice is to transition them to a full agonist like 7 days before, something like that. Again, I'm not a pain expert, but this is my opinion. Transition to something like oxycodone so that they have that in their system, and then they go to surgery, and now they won't have that partial agonist that may precipitate a pain crisis. All right, I know there's a lot more to say about opiates and stuff, and I'm moving kind of fast, but I'm going to move on to alcohol. And I just want to take a step back and I want you to consider how bizarre it is that alcohol is a legal drug that in the United States that you can get when you're 21 legally, or in other states you can get possibly, or other countries you can get possibly when you're younger, and it's legal, and it is so incredibly dangerous for the human body. It is so incredibly dangerous on public health. And then you have something like marijuana, which traditionally has been illegal for so long and has been used and weaponized to criminalize large swaths of people that are usually non-white people in the United States, and to create a carceral state that's completely unjust. Just step back and think about how bizarre. There's a lot of bizarre things about our society, many, right? American society and Western society and global society, right? I mean, there's a lot of bizarre things everywhere. But this is truly one of those things that's just like, why would you not legalize marijuana? Why would you not decriminalize a bunch of people when you have this insane double standard? Think about this, okay? It's just like, do you understand how bizarre it would be to say to someone, hey, we're getting together, we got happy hour, we're all going to, smoke a couple bowls, come join us for happy hour. Do you know how that is not socially acceptable? But it is socially acceptable to be like, let's go meet up for drinks. When alcohol is so much worse for your body and so much worse for society. The stigmatization of marijuana is just, it's insane. It's insane. And marijuana is it's so much more harm, it does so much less harm to the human body and less social impact than alcohol. I just want you to, I know it's not that profound. I'm not the first person to make this observation, but that is just something so incredibly bizarre about our society. Anyway, so let's talk about alcohol, which is a drug, and it's absolutely terrible for your body, and no amount of it is good for your body. I just want to dispel that myth right now, right? Like, people are like, oh, wine, I drink a glass of wine, blah, 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 for heart health. Well, yeah, there's a substance in wine that may be good for heart health, but it's not the alcohol in wine. You go drink non-alcoholic wine if you want that benefit, right? Don't use that as an excuse. Alcohol is not good for your body. No amount of alcohol is good for your body. Your liver has to process that alcohol. It's not good. It's not good. If you're someone who, no, never mind. I don't want to get into too much in giving like advice about stuff like this. But just know that no amount of alcohol is good for your body. The less alcohol you can drink, the better for your long-term health and longevity. And just to put it out there, I do not drink alcohol. I do not drink it. I don't drink a drop of alcohol. I know, I'm weird. I don't do any illicit drugs or anything. I drink caffeine. That's my drug, and it's amazing. Anyway, let's get on to this. So when I ask a patient, so the reason we do you drink alcohol? How much do you drink? Again, it's not a moral judgment. We need to know, especially with alcohol, because withdrawal from alcohol is deadly. It can be deadly. It can cause seizures and you can die. Again, withdrawal from opiates is not deadly. Withdrawal from alcohol absolutely can be deadly, and people can die from withdrawal of alcohol. So we need to know. And people, if they say no, I don't drink at all, then it's like, okay. Some people will be like, oh yeah, I drink a gallon of vodka a day, and they'll say that like it's just nothing, and you're like, oh, okay, that person needs alcohol or benzos in their body. So benzodiazepines hit the same receptors as alcohol. And that's why withdrawal from benzos. I'm going to be discussing kind of benzos in here as well. Benzodiazepines, like clonazepam, lorazepam, midazolam, Xanax, which is alprazolam. These are benzodiazepines. They hit the same receptors as alcohol. That's why the treatment for alcohol withdrawals is benzos. That's what we give to someone in the inpatient setting when they're going to withdraw from alcohol. And you must treat them with benzos. It's not just to like, oh, we don't want them to have a bad time withdrawing from alcohol. You have to treat them. They can die. They can have seizures and die if you do not treat their alcohol withdrawals. And people usually drink more than they report. That's not across the board. And I don't make that judgment every time, but people they usually, if someone's like, here's the thing, if someone says, oh, I drink on the weekends, that's, okay, cool. If someone says, I drink, a couple beers a day, that's someone that starts to pique my interest, being like, this is someone who may withdraw from alcohol and it may be a danger to their health. So again, it's not a judgment I'm making. So if someone says, oh, I just drink a little bit on the weekend, I'm not that suspicious that person's going to have withdrawal, bad seizures and die. But if someone says I drink a couple beers a day, my suspicion is raised that this person likely maybe been an alcoholic, which I know that term has bad connotations. Again, I'm sorry if I'm offending people with my terminology. I just can't use it's hard to constantly be aware of my language all the time, which is not an excuse. But anyway, my apologies up front. But if someone says I'm drinking alcohol, I drink a couple beers a day, I'm like, I'm alerted that this patient maybe have withdrawal symptoms as they're admitted to the hospital, and they may need benzos. We may need to monitor that because it could be dangerous to their health. If they say they're drinking a couple beers a day, they're probably underestimating and underreporting what they drink. They probably drink more a day. If someone is drinking alcohol every single day, they're at danger of having withdrawal problems. So, there are mild withdrawal symptoms: insomnia, being tremulous, shaky, anxiety, headache, having heart palpitations or being sweaty. Those are mild symptoms. The severe symptoms are withdrawal seizures. So there's withdrawal seizures. They can be generalized tonic-clonic convulsions that we talk about, and they can happen anywhere from 12 to 48 hours after the last alcoholic drink. But sometimes they can occur after a few hours, as few as 2 hours after abstinence. That's why we always ask when someone has alcohol substance use disorder. We'll ask, when is the last drink? When is the last time you had your drink? And if you are someone who has substance use disorder with alcohol, be honest. Be like, my last drink was at 6 p.m. We need to know, because we need to start timing. Okay, when is the danger of them having seizures? And again, seizures usually occur with patients with a long history of chronic alcoholism. So as I said, we usually treat these with benzodiazepines. Phenobarbital can also be an effective treatment, which is a barbiturate. And then if someone's withdrawal seizures are so bad, sometimes we put them in a medically induced coma. Propofol also can prevent withdrawal seizures. Sometimes someone can be they can be intubated and sedated for a different reason, and then they have alcohol issues. So like if someone has been drinking a gallon of vodka every day and they get in a car accident for whatever reason, they come in and they're intubated, they have traumatic injuries to their body, whatever, maybe they had a brain bleed, et cetera, and they're intubated, and sedated, they can go on a withdrawal. But propofol will keep that at bay. But once you start waking up, they can be in alcohol withdrawal. It's something you must be aware of with patients like this, and something you should be suspicious of if things aren't adding up, that maybe they're in withdrawal from alcohol. So with alcohol withdrawal, there's something called delirium tremens. which is about 5% of patients who undergo withdrawal, they suffer from this, DT. And it's defined by hallucinations, disorientation, tachycardia, hypertension, hyperthermia, agitation, sweating, and in the setting of, reduction or abstinence from alcohol. The DTs, as I said, they can begin between 48 and 96 hours after the last drink, and it can last up to 5 days. DT, delirium tremens, and alcohol-like hallucinations are not synonymous. The symptoms that occur a few hours after the cessation of drinking, even if they're severe, are usually not manifestations of DT. Now, the risk factors for DT are obviously a history of sustained drinking, a history of alcohol withdrawal seizures, a history of DT, obviously, age greater than 30, the presence of other illnesses, and also the presence of significant alcohol withdrawal in the presence of an elevated blood alcohol concentration. So if someone has their blood is saturated with alcohol and they're withdrawing, that's a big risk factor that they're going to have DTs and seizures. When DTs are identified and appropriate management is given, the mortality from it is less than 5%. Now, there's a protocol that's used universally in the United States. I don't know about globally. It's called the CIWA protocol. It stands for Clinical Institute Withdrawal Assessment for Alcohol. And this is a bedside checklist that the nurse makes to give a numbered score to how severe is someone's withdrawal. And there's usually a pharmacological protocol set up that if they score this many points, you give them, a benzodiazepine or phenobarbital, depending on the protocol. And I'm not going to comment on how much benzos to give and phenobarbital to give here. I'm not going to make those medical recommendations. That should be institution dependent. I don't want to cause unsafe practices because I'm being too vague, so I'm not going to talk about that at all. But the CIWA, it's usually based on, are they having nausea and vomiting? Are they sweaty? Do they have anxiety? Do they have a headache? Do they have auditory hallucinations? Do they have visual hallucinations? Are they agitated? Do they have tactile disturbances? Do they have tremors? Are they not oriented? So the bedside nurse makes a score of these. So a severe withdrawal is like greater than 20. Anyway, you can look up the protocol. It's called the CIWA protocol, CIWA. It's extremely, extremely important and well-validated tool. All right, moving on. Let's talk about methamphetamine. So it's what we call sympathomimetic, which stimulates the sympathetic system or stimulates your fight or flight response. It can have like anorexic effects, euphoric effects, hallucinogenic effects. So that's why it's a disease, a drug of abuse, is because it causes euphoria and maybe hallucinogenic effects. But it's also, methamphetamines are used clinically for treatment of attention deficit disorder with hyperactivity. Sometimes it can be used for short-term obesity treatment, which is not something I'm knowledgeable about. I don't know why we use it. I don't prescribe it for that, so I don't come at me for that. And it's also can be used off-label treatment for narcolepsy. Recreational use of methamphetamines and other amphetamine-derived stimulants is an epidemic in the United States, also in Southern Asia, the Philippines, Japan. After cannabis, it's the most widely abused illicit drug worldwide. About 5% of the United States population has used methamphetamine in their lifetime, with an estimated 500,000 people using the drug in any given month. So, chronic methamphetamine substance use users, they're usually malnourished, they're agitated, they usually have signs of like hypervigilance. That can be even just mildly intoxicated patients. Lots of changes in sleep patterns, severe mood changes, unpredictable behavior are very common. They can have excoriations or like track marks on their skin, and that's really suggestive of prolonged intravenous use. They can have profound sweating, diaphoresis. Anyway, there is definitely, I know it sounds bad, but there is a look of methamphetamine abusers. So methamphetamine abusers, they usually, they can have, as I said, they can have extreme agitation and they have deranged vital signs. They usually have a dose-dependent variations of blood pressure. They can be hyperthermic with high blood pressure, elevations in their heart rate, and at the higher doses generally seen in like acute intoxication, they can have that sympathomimetic stimulation or that fight or flight response that can be dramatic, a dramatic increase in heart rate, blood pressure, respiratory rate. Again, elevated temperature is very common, and they can have arrhythmias, tachyarrhythmias, associated with severe intoxication. Lots of patients can have heart failure, methamphetamine-induced cardiomyopathy, which can happen. It's a disease that really destroys the body in very significant ways. So the general approach to someone with acute intoxication of methamphetamine is they can be so agitated, they can pose a danger to themselves, other patients, and medical staff. And I've seen this many, many times. So you have to have control of violent behavior. It's critical. They must be treated. Acute intoxication must be treated usually with intravenous benzodiazepines, like lorazepam, midazolam. Sometimes you have to give this intramuscularly because you can't even give an IV in these patients. They're in such danger to themselves. They won't allow you to put an IV in. So you have to come along and put, intramuscular medication, you just put a needle in their muscle and inject the drug and get out of there real quick while security guards hold them down. I've done it. I've definitely done it many times. Oftentimes, severely intoxicated patients they need to be intubated. They need to be out and intubated. Sometimes they've hurt themselves so badly, you need to scan them for traumatic injuries, and you can't do that because they're so agitated that you have to sedate them, intubate them, put them in a breathing tube, send them to a scanner, get the workup done. Oftentimes you have to chemically control these patients for their own good, for their own safety, to even do a diagnostic workup on them to see if there's anything else going on. Because it's not just they can have methamphetamine-induced toxicity, that they can have other things going on, like traumatic injuries to their body that can be very harmful if they're not recognized and treated. Now, acute withdrawal leads to like crazy derangements in neurochemistry, and that can lead to compulsive and uncontrolled drug intake with their addiction, particularly after heavy or prolonged use. Abrupt discontinuation of methamphetamine can cause a withdrawal syndrome. Symptoms may develop within hours. They typically peak within 1 to 2 days, and most often decrease within about 2 weeks. During the acute withdrawal phase, the signs and symptoms are like dysphoria, just feeling awful, fatigue, sleeping a lot, vivid dreams, sometimes not sleeping, insomnia, agitation, anxiety, drug craving, and increased appetite. It can be similar to acute intoxication, but maybe not as severe. And then treatments for acute withdrawal include, again, benzos, antidepressants, antipsychotics, naltrexone, and then, of course, behavioral therapy. And again, this is not my field. I'm not a psychiatrist. I'm not a substance use expert. So I don't want to comment too much on treating methamphetamine use. But it is a very terrible disease, methamphetamine addiction, that systematically destroys someone's mind and body. So the last illicit drug I'm going to talk about today is cocaine, which is a ester alkaloid. It's found in the coca plant, which is a bush that grows in the Andes Mountains. It can lead to, obviously, addiction and a lot of adverse physical effects. It can lead to stroke and cardiac arrest. It's a very dangerous drug. So, according to an annual world report that I'm looking at, cocaine is estimated to have been used by 20 million people worldwide, or about 0.4% of the global population aged 15 to 64. Its use is most prevalent in North and South America, Western and Central Europe. Cocaine use and its disorder represent a really significant health burden. Cocaine overdose is like a less common cause of mortality than the other medications I'm talking about. Of about 16,000 overdose deaths involving cocaine in the United States in 2019, 2/3 also involve synthetic opiates like fentanyl. Again, like a lot of drugs, there's a comorbidity with cocaine use and other psychiatric disorders like anxiety, depression, bipolarism, and schizophrenia. So withdrawal from cocaine, of a chronic user is usually associated with things like depression, anxiety, fatigue, can't concentrate, something called anhedonia, which is like not enjoying things that you usually enjoy. Of course, increased cocaine cravings, increased appetite, sleep disturbances, and like insomnia or hypersomnia, and disturbing dreams. As opposed to the other drugs I've discussed, the physical signs of cocaine withdrawal are usually minor, and they actually don't really require treatment. Usually it's like nonspecific musculoskeletal pain, chills, bradycardia, a low heart rate, are kind of the signs of withdrawal. Complications associated with using cocaine are, acute intoxication or seizure. That can occur after like a large dose of cocaine in individuals with that have a background of seizure as well. Stroke, people can get stroke from acute intoxication. Some other movement disorders, headaches, are also things that can happen. There's psychiatric effects like suicidal ideation and cocaine-induced psychosis, which can obviously have all sorts of problems. Hypertension, high blood pressure, high heart rate, And then you can get there's others. Basically, acute intoxication of cocaine can affect all organ systems of your body in different ways. All right, I think I'm going to just wrap up my discussion about that. Let's move on to the book of the week here. All right, I'm going to talk about a book that I very much disliked, and I knew that I probably would before I read it, and I'm going to explain very specifically why I did not like this book. This book is called Woke Inc. Inside Corporate America's Social Justice Scam by Vivek Ramaswamy. Ramaswamy is he's like a CEO of the pharmaceutical industry. And he wrote this book where he's honestly, to sum it up, he's trying to rebrand corruption and repurpose it as wokeism. I know there's a lot of, as I use the word woke, I want to be very specific here. I know that, wokeism has many different connotations at this point. It's been co-opted and weaponized as a pejorative also. What probably should have started out as like a civil rights movement. Wokeism has become this whole thing, and it's a big ball of wax that I'm not going to get into, but I'm using the word in a specific way here as I talk about this review, and it's mostly in the term that the wokeism and woke has been co-opted by corporations to, and exploited by corporations to, in marketing campaigns to basically pander to liberal-minded people to make money, right? And that's how I'm using it here. So please, forgive me if that may be offensive the way I'm using it. Basically, this author is trying to rebrand corporate corruption. So it's an interesting perspective from this guy. He offers an unabashed tirade against state and corporate collusion, which is something I love to complain about, with some very accurate insights, while he also seriously conflates concepts to mold into this grand polemic about what he perceives wokeism to entail. A big part of the book is the debate between the virtues of stakeholder capitalism and shareholder capitalism. Stakeholder capitalism asserts that corporations should operate with all stakeholder interests, including shareholders, customers, and the greater public good. Shareholder capitalism is that all interests and goals should be entirely devoted to boosting shareholder profits, as it is the fiduciary duty of the managerial class to do so. The author argues that stakeholder capitalism lends to corporations being involved in social causes and making themselves the unwanted stewards of advancing social change. Since they are not elected and only care about corporate self-interest, this makes them wholly unqualified to be involved in philanthropy, which is a reasonable conclusion. Such causes inevitably turn into a form of cultural authoritarianism, paying lip service while paradoxically destroying cultures, people, and wealth both domestic and abroad. And I agree with this point. Many examples abound in the book, from Google and Apple ignoring human rights violations in Xinjiang, China, while having a little BLM logo on their website, right? It's absolute hypocrisy. And this stuff is all over the place, and it's also incredibly obvious to many, many people. This isn't a profound point that the author thinks is as profound as he thinks it is. He's not teaching you anything. It's obvious, right? He really beats a dead horse about a phenomenon that is really, really obvious about corporate motivations. And the author clearly endorses shareholder capitalism and valorizes the fiduciary duty of what he considers an increasingly belligerent managerial class that they have to their shareholders. Both public and private, the author scolds the managerial class for trying to seize both state and corporate power from the people and the shareholders, respectively. He argues that shareholder capitalism ensures that corporations stay in their lane and not take up social causes and not deceive the public and but profiting from that. And I certainly think there's a case to be made for this, but there's a glaring problem with his logic. Why is shareholder capitalism actually good for society in its own right? He never talks about that. He never explains how increasing short-term profits for a small group of people is a win for the public good. The reason he doesn't explain it, maybe, is because it isn't good. Wealth concentration is bad. And it's bad for some of the very reasons he talks about, that wealth power spills over to public control. I very much agree with his assessment of Section 230 and how our tech overlords are subverting democracy and the public good with Section 230. His best point is that corporations shouldn't dictate what is moral and ethical, and they definitely do by their default power, and they leverage that into cultural liberalism. They leverage it from cultural liberalism. They co-opt it. I agree with the author that, quote, wokeism is becoming a monolithic, dominant cultural force that demands conformity of thought in academia and in the workplace. It does. It truly does. This can be potentially harmful to productive discourse and it can erode the public good. I do think that there is merit in discussing that. I know I hate using this term as much as anyone else, but cancel culture, in my opinion, is a serious threat to free thought. People should not be fired or ostracized for voicing opinions or their thoughts and their views that are counter to mainstream liberal thought, as long as those views aren't outright hateful or inciting to violence. That's just my opinion. Where the author overreaches is calling wokeism a literal religion, evoking words like blood sacrifice and worship. These are his words. Not only is this highly demeaning to people of actual religious faith, but it's completely inaccurate. A religion has codified doctrine, central authority, acolytes, and an underlying spirituality. Wokeism may appear to have these things, but it's like a bastardized version at best. The author is conflating religion with ethos. So this is where things get problematic for me also. This guy has a love affair with what he perceives as capitalism and clearly endorses free market solutions. He goes as far as to argue that capitalism abolished the caste system in India. This kind of sweeping claim had me really raising my eyebrows early on in this book. As a CEO, it's very clear that his worldview has coalesced into believing that market solutions naturally address society's problems. I don't know if that's like self-delusion or he's just naive. Either way, it's not accurate. And I want to dig in a little more here. The author blames the government for the 2008 financial crisis. Okay. In a sweeping accusation, he states that the housing, quote, policies in the 90s created too much liquidity in the housing market and caused an asset bubble that burst 15 years later. Others have made similar arguments that the FHA, the HOLSC, and the Community Reinvestment Act, the CRA, have been used to provide easier public loans through government-sponsored enterprises called GSEs, like Fannie and Freddie, that they fueled the housing bubble. I have some bad news for this author and people that think like this. You're wrong. You're demonstrably wrong. Here's the facts. The facts are that consumers who already had mortgages and who built up equity in their homes were more likely to be targeted by subprime loans than first-time home buyers. The crisis was caused by the rise of private predatory lending, not GSEs. FHA loans have never dominated the markets, ever. In fact, FHA loans had less market share, going from 14% to 3% from 2001 to 2007. Delinquency rates were also lower for those loans. GSE loans had delinquency rates of 6% during that time, while private loans were 28%. So how could public-backed loans fuel an asset bubble when they had a tiny portion of the market share? And of the defaulted loans, only 6% were the CRA, the Community Reinvestment Act loans. It was clearly an unregulated mortgage-backed security market that led to the bubble. It seems like a business titan like this author would be able to understand this. Here's what he's doing with this book, okay? He's taking an age-old phenomenon, which is tokenism, and he's rebranding it as a new left-wing authoritarian Orwellian nightmare and then repurposing that as wokeism. That's what he's doing. Both companies and public entities use the politics of inclusion and tokenism to gain popular support and then go about doing whatever they want. We all know this. But the author is trying to act like it's a new left-wing phenomenon that's subverting democracy. The point he's missing is that it is big business, monopolization, and state corporate collusion by any social and political means that is destroying democracy. It's not just the, quote, woke industrial complex, which is a term he uses. By compartmentalizing it as just a left-wing phenomenon, he has huge blinders on that become evident as the book goes on, with mountains and mountains of confirmation bias. The author denies that systemic racism is a current American phenomenon. Why does he do this? It's because he's conflating individual racial prejudice with de facto racial apartheid. He clearly does not understand that the de jure racial government policies that are the literal foundation of the United States, from the Homestead Act to the GI Bill, the FHA, HOLC, New Deal programs, the drug war, 3 strikes felony charges, subprime lending, all of this, the United States has the bones of a literal racial apartheid. The author doesn't think for a minute that there is some residual systemic racial prejudice going on as a fallout from those race-selective policies. Come on. That's ridiculous. Of course there is. The gall to deny that American institutions may have implicit race preference and to cast racism as a woke corporate charade is a sign of someone who hasn't done a lot of reading or thinking outside of his own echo chamber. So, okay, what's the impact of a book like this? There's two things: confirmation to those that already think this way, and obfuscation to those who are confused about how power actually operates in the United States. This book, and many like it that I've read, serve to deny real subjugation that is very much active in American society. It's ultimately the manifesto of a deluded rich man who wants you to know how much he and others like him have done for you. So I found the book worthwhile to read to understand why someone thinks this way, so I do recommend reading it, but maybe get it from the library like I did, and don't pay this guy. Anyway, I think I'm done. I don't think I can get to questions today. So let me know how you like the podcast. Give a review. Share it with someone. You can email me at icudoctorecmo, ECMO at Gmail, icudoctorecmo at Gmail. I'm on TikTok. My handle is icudoctor. I'm on Instagram. You can DM me there. ICU Doctor TikTok, my Instagram handle. And thanks for listening. Appreciate it. Bye.